que não estão acostumados com a plataforma, e acho que essa altura do campeonato, depois da pandemia de webinar, todo mundo já sabe usar isso. Mas a gente, mais uma vez, está fazendo uma live. Na verdade, esse não faz parte de uma sequência de cursos, mas uma live com o Mike, que dispensa apresentações. E se alguém tiver interesse em fazer perguntas, a gente pode usar a ferramenta Q&A, Q&A, para fazer perguntas direto, e todos os participantes podem direcionar perguntas, e a gente aqui da organização vai tentar responder algumas por texto e traduzir outras que forem necessárias para o Mike Kelly direto. E ao final da apresentação dele, se alguém quiser fazer uma pergunta com o microfone aberto, é só usar a ferramenta levantar a mão, raise hands, essa mãozinha aí na parte de baixo, que a gente pode eleger você para fazer a sua pergunta de forma oral direto para o Mike. Obrigado a todos mais uma vez pela presença, e vamos dar sequência para a gente não atrasar o programa. Ok, Mike, up to you.
All right. Does this look right now? You don't see like the notes and stuff, do you?
No, just the presentation.
Okay, good. Okay, so this, I spoke with you guys, and we wanted to talk a little bit about a couple of the important papers in adult spinal deformity that we have participated in here at Washington University. So we'll go over those, but I wanted to give a little bit of a history about how we got to doing those papers, because none of these big important papers really fall out of the sky. It all involves quite a bit of planning. So adult spinal deformity, there are many adult spinal deformities out there in the population. The prevalence is up to 1/4 of people, 1 in 4 people. And then once you get older, not unexpectedly with degeneration of the low back, prevalence of radiographic deformity is over 50%. The vast majority of that, though, is asymptomatic, right? That's very, like, those are very classic papers that we talk about for asymptomatic neural compression in both the cervical MRIs and in lumbar MRIs. Scott Bowden's paper is the one we ask our residents about all the time, that as you get older, you get an MRI on a 70-year-old, you're bound to see some stenosis, but whether or not that stenosis is symptomatic is entirely unrelated. And it's the same for spinal deformity. When spinal deformity becomes symptomatic, however, though, it is quite problematic. And when you look at SF-36, which is a general measure of health, the disability associated with adult spinal deformity is not different from cancer, diabetes, and then this one just made me laugh, limited use of arms and legs. I'm not entirely sure what that is, doesn't sound good. But symptomatic adult deformity is with cancer, heart disease, diabetes, and it's actually worse than back pain, which is not too far off from normal. So the first cohort that studied this in any type of really rigorous fashion was the Spinal Deformity Study Group. And that was Keith Bridwell, Steve Glassman from Leatherman, Sig Bervin from UCSF, John Costwick at Hopkins, and Bill Horton at Emory. And they got together and they started enrolling patients just like ISSG and ESSG and BSSG to just follow them. No particular interventions, just sort of what have you done, what are we doing to you, and how are you doing? And so in this study group, they looked at so people that don't have surgery, non-surgical resource utilization. And what they found was you spent a little bit of money, but they essentially got no better. And the problem with that is that if you start spending a little bit of money on a very broad scale and they get no better, there's no value there. And I don't know what the healthcare system status is in Brazil, but value-driven healthcare is a very big, there's a big push for it here now, which I think is very reasonable, where value in its simplest terms is quality of life improvement divided by cost. So if something provides really impressive quality of life improvements, but is expensive, it might actually provide value. Whereas, is non-operative care worth the cost? Is there any value in non-operative care for symptomatic adult scoliosis? It sure seems like no, because in general, they have no change in HRQOL despite spending this money. And when you convert that to quality adjusted life years, so the amount you pay to give someone 1 year of very good health, it's outrageously high. because you can see here, these are not relative to what we do and what we spend and how much like one large kit of BMP costs here. This is not a lot of money relative to surgeries, but they don't improve. So the cost per health-related quality of life gain is terrible. And as I had on the last slide, this is 2002 to 2004. That's almost 20 years ago now. And what did we do? We gave them opioids. And you all know, like, especially in the United States, tons of opioids. It's embarrassing when we presented at the SRS and have colleagues like you guys and the guys from Europe that say, we just don't give it to them. This is, you guys are creating this problem. Lots of injections, lots of physical therapy. I think at least we have gotten away from bed rest, but we still use these other things frequently. And they tend not to work. So what's the alternative, right? And this is still working in the SDSG. The alternative is surgery. So they also studied surgery within the SDSG. And as I said, this is very expensive. It's really expensive, and it's going to be that expensive. Then we need to show that surgery actually works. And so does it work? And that's the subject of numerous studies from the SDSG, the ISSG, the European Spine Study Group, single center studies, administrative database research, and you need to be cautious of the conclusions drawn from all of these. There's substantial biases in these registries, including sometimes as I'm a participant in the ISSG, is that if you sometimes these patients that look like they're not going to do that well, maybe they're not going to follow up, you don't enroll them in the study. So you have loss to follow up because they're non-consecutive. Their treatment arms are non-randomized. I think all of us on this call are probably surgeons. Just to some extent, we kind of understand that randomization is not something that we should require or call for in our research. I hate to say like the eggheads, but the real sort of methodological, sort of very strict traditional people, they want randomization to really prove that something works. Whereas most of us would say, look, it's the whole parachute thing. I don't need a parachute or a randomized study about jumping out of an airplane with or without parachutes to tell me I need a parachute. So requiring randomization may not be the best, and we'll see that later when we talk about ASLS. There's tremendous performance bias in these studies when you have so many surgeons doing it. I think all of us know that there are some outstanding surgeons that get up on the podium and give talks, and then there are some people that, as I was taught, they were called oral surgeons in my residency program, where they love to talk about surgery, but they can't actually do it very well. And when you lump all those, the technically outstanding with the technically average with the technically not very good, that muddies it and biases you towards, if the surgery doesn't work, biases you towards the mean. There's confounding by indication because of the heterogeneous nature of adult spinal deformity. There's revisions, there's flat backs, there's iatrogenic flat backs, there's degenerative flat backs, there's neglected idiopathic scoliosis, there's de novo adult degenerative scoliosis. All of those things kind of change because you call it adult spinal deformity, whereas there's a number of finer diagnoses within that cohort of patients. And really what also is very important in these studies is that the loss to follow-up can be extreme. And when you have loss to follow-up, a lot of the times, if you read the papers that, and I'm on these papers in Spine and JNS Spine and the Spine Journal, it's just never really discussed. It gets this very nice hand wave, and we all tend to just sort of ignore the fact that there's loss to follow-up that may substantially affect the conclusions that you draw, particularly if the people that are lost to follow-up are not coming back to you because they hate your guts, because they're no better, and maybe they need a revision and they want nothing to do with the revision. That's sort of the nihilist way of looking at it. There are some studies in cervical spine, at least, that say loss to follow-up is not a big problem because those loss to follow-up are generally not different from those that are attendant to their visits, and most of them are quite happy with their results. And then smaller studies exist, and power and external validity are concerns when they get too small. So what was the SDSG experience? This is Keith Bridwell's. He kind of led the adult arm, and Larry Lenke led the pediatric arm of the SDSG. So they looked at those patients with minimum 2-year follow-up They had over half of the non-operative cohort lost, but what they showed is that surgery tends to work. Non-randomized, just looking at their health-related quality of life scores by the SRS subscore, surgery works. And non-op, while this goes down, this is probably not actually different. I doubt that this is a statistical difference and certainly not a meaningful difference. Non-op tends not to change, and surgery patients do work. Leg pain improves the most with surgery. I don't think that would surprise any of us that relieving neural compression is the best. That's one of the old tenets, right, of spine surgery is don't operate on back pain, relieve nerve pain, and you'll have generally reasonably happy patients. We have a fellow this year from Harvard who trained with James Kang, who is a very old school guy, and he tries not to fuse anyone over 60 years of age and just decompresses them. And generally seems, according to our fellow, to have very happy patients where they'll say, oh, my back hurts, and he'll do the yeah, but your legs don't hurt. And they're like, that's true, my legs don't hurt. My back hurts, but my legs do feel better. So this sort of just affirms that we know that relieving neural compression tends to work. So surgery seems better, it's expensive, and then the results at 2 years seemed durable for surgery. How does this contrast? So the ISSG started as the Isola study group about the same time as the Spinal Deformity study group. And then once Spinal Deformity study group sort of dissolved, ISSG took over and is now a massive cohort of patients. They published our 2-year follow-up of about 600 patients. Again, loss to follow-up in the non-ops was 45% and 14% in the operative for 2 years. That's not very good. You'd like it to be a little bit higher. The findings are largely consistent with the Spinal Deformity study group. But if you look at it carefully, again, looking at mean change, if you just imagine three people in a group, and if you say mean change is a half, but one person improved 2, and then the other 2 people improved very little, the average change might be a half, but only one person did really well, and the other people didn't do very well. So a responder analysis is the appropriate way, I think, to use the idea of the minimum clinically important difference, which I could talk for hours about why that's not something we should really be doing anyway. But only half of people achieved MCID for the ODI, a little over half for the SF36 PCS, and that is pretty consistent with the European Spine Study Group. In brief, one of the reasons why I don't love MCID for adult spinal deformity is because it's the minimum clinically important difference. It is the smallest change deemed important to the patient, the smallest, in the absence of risk or cost. And we'll come to it later on that I've already said that these are very costly surgeries. These are also very risky surgeries. So we are not talking about something in the absence of risk or cost. We are talking about huge costs and great risks. So patients, telling someone, well, you're barely better enough to notice it, I don't think that's appropriate. I think that we should do surgeries where they say, I am really better, and that was a great idea. So now coming to the adult symptomatic lumbar scoliosis study, seeking the highest quality evidence for evidence-based healthcare and value-driven is that you need level 1 data. And then I put in parentheses, but is it? Because I think we could debate all night whether or not there's appropriate ways to study surgery versus non-surgery. But level 1 data is randomized treatment allocation, right? You get patients and you randomly give some surgery and you randomly put others into non-operative care. And then you can compare them because the randomization should distribute both the known and the unknown confounding variables, the things that are within that patient that can potentially affect their outcome. I think one of the things that we need to be cautious about with this, and especially with demanding level 1 data, is that the statistical methodologies we have now, we can control for a lot of the measurable and captured confounders. What we cannot control for, and why we need randomization for things like this, is because we can't capture the patient's a priori sort of feeling about what is, do I need surgery? Is surgery going to work? What they believe inside about what the next step for them is. There's no way to control for that, and that's why you'll see also that these studies don't work. It's sort of a circular logic problem. I think beginning ASLS we needed to be appropriately cautious given the prior experience from the patient-reported outcomes trial, SPORT, where they looked at lumbar spinal stenosis, degenerative spondylolisthesis, and lumbar herniated discs. Crossover or not adherence in those studies were massive, making randomization. You could randomize, but the people would cross over and then they'd ruin your randomization, because people that you randomized to non-operative care would then say, oh, I don't want to do that, I want surgery, and then you have to let them have surgery. And so it's difficult in the United States. At the SRS, a couple times I've talked to the guys from the UK, and they have a way that they're with their socialized healthcare system, the wait list to get surgery is so long that they are pretty confident that they can do the study, that even if someone says, no, I'm sick of this, I want surgery, they're going to say, okay, your surgery is in 18 months, and they'll be able to treat them non-operatively for 2 years to get it there. So Keith Bridwell, with the other gentleman from the Spinal Deformity Study Group, wrote an NIH grant, Adult Symptomatic Lumbar Scoliosis. It was R01 funded, 9 North American centers. The inclusion criteria were 40, 80-year-olds, lumbar curve greater than 30 degrees, an ODI greater than 20 degrees, or an SRS domain less than 4. They had to have they could have 1 or 2 level decompressions before only. They could not have had an instrumented spine fusion before, obviously, and no infections or anything like that. So it was fairly straightforward adult deformities. Here's the flow diagram, so that there are 306 people that were consented, 276. So we saw, what, 582? Half of the people said, I want nothing to do with your study, which again, I mean, just think about it. That's half of the people that you're treating, you're not getting any data on. 286 actually enrolled, but only 63 enrolled in the randomized cohort, almost 30 per group. At 1 year, half of the non-operative had undergone surgery, and at 2 years, more than half of the non-operative had undergone surgery. There were some delays to getting people assigned to operative care to surgery. When you do a study like this, it's always nice to say, okay, well, let's do a study where if they don't want to randomize, we just watch them carefully. So this is the observational cohort. These are people that declined randomization. They had no interest in having a computer tell them what their treatment was going to be. 111 chose non-operative care, and they were actually, again, should not really be a surprise, because this is what they have chosen. They've come in with this preconceived notion that they don't want surgery and that surgery is not for them. Rarely underwent surgery. And then people that want surgery, they get surgery. I tried to put all of the papers that we have published from ASLS into the talk so that we get a very good overall picture of what the database has done. ASLS studied primary coronal plane deformities for the most part. There were very few sagittal plane deformities. Only 10% of the patients had gross sagittal plane deformities of almost 10 centimeters or more. Over half of them stood with very good C7 plums, 63% less than 4 centimeters. For that reason, there were no real correlations with any radiographic parameters and their health-related quality of life scores. And I think in part that's because there were few truly deformed sagittal profiles. The conclusion of this paper, this was Matt Chapman, who's now at Ortho Carolina, was don't rely on radiographs to estimate the disability. I think that that's true. I wouldn't argue with that. It supports the notion of relatively asymptomatic spinal deformities. And a prime example is age-related change, where you age, the discs degenerate, maybe you get some asymmetric collapse, leads to the scoliosis, a little subluxation. This was not asymptomatic, but you could certainly imagine in your mind that this patient would come in and not have great problems. I think it does not support the notion of age-adjusted alignment parameters or fixing without alignment targets. We recently did I am not an age-adjusted alignment believer, with something we can talk about later on tonight if you guys would like to. I am more of a believer of the way the Europeans like Ahmet Alane and those guys think about it. If you read those papers about age-adjusted alignment targets, it's really very, very not good. So it's primary deformities, very little sagittal plane deformity. And then we also looked at how do the patients that elect to be randomized or crossover, how are they different or the same from everyone else? So one, as I said, randomization is very difficult, and adherence was even worse. People that randomized were by and large similar or not different to people that said, I want to be observational and I want surgery. So the people that randomized tended to be worse, but were willing to sort of let the computer happen. And they were distinctly different than people that said, I don't want surgery. Then within the study, people that crossed over from non-operative to operative, not surprisingly, had worse health-related quality of life scores. You can see 0.5 difference in SRS subscore, 14-point difference in the ODI, and 3-point difference in leg pain. So the adherent ones didn't have a whole lot of leg pain. The crossovers did have more leg pain. This is worth looking at because the observational surgical patients, right? The patients that came in and said, I want surgery, their baseline ODI also tended to be around 40. The crossovers tended to be around 40. And when I talked to Tom Errico about sport, that was the same in sport, was that the crossovers in sport for degens bondi, spinal stenosis, also tended to have ODIs around 40. So one of the takeaways from my practice with this is that when a patient has an ODI of less than 40 and they're really on the fence about what to do, I say, you're not bad enough yet. You will know. And I collect an ODI on everybody. I go over, this is the score. Under 20, you shouldn't even consider surgery. 20 to 40, it's up to you. But if you're on the fence, you should wait, because it sure seems that people that need or want surgery have more pain than you have right now. Because I don't like pushing them into it. So if their ODI is under 40, that's the spiel they get. If they're on the fence and they're over 40, then I also tell them, well, you know, a lot of people are like you, and by and large, those people tended to have surgery. Go home and think about it. But 40 seems to be a critical number and very useful in practice. So now for the 2-year analysis, now people were randomized, they were treated. When you do a randomized trial, there are multiple ways to look at the data. One is intention to treat. Intention to treat is where you ignore what actually happened to them and you just compare the people randomized to surgery to the people randomized to non-operative care, irrespective of how many people in this non-operative care actually had surgery, and you compare the two. And that preserves the effects of randomization to balance all of the other things that you can't measure. And in some cases, and if an intention to treat can still show statistical differences, if your crossover is low enough, your non-adherence, it doesn't reach some critical number, and the effect size or the difference between surgery and not surgery is large enough. And one of the real disappointing things for me is that ASLS was written with the SRS in mind, where 2 years was the minimum follow-up required. And if you look here, the intention to treat, it was significant at 1 year. It lost significance at 2 years with a very small, where the treatment effects merged to the mean, because crossover was so much more. If you remember back to the flow diagram, here crossover is 45%. Here crossover is over 60%. And those last couple patients were able to nudge this over into not significant. The same thing happened for ODI. Within 1 year, the treatment effect was huge. There was crossover, but it was still significant. At 2 years, significance was lost because non-adherence and crossover, and the number of people in this group that had a benefit in their HRQOL from surgery was too large. So then we combined the groups and just did an as treated. So we just looked at people that were treated with surgery and people that were treated with not surgery. And in these, because you don't have randomization, then you need to do fancy statistics where we did a model to look for all of these little time points, and we controlled for, and these were decided in advance: age, body mass index, mental health, and I would say, you know, a more modern way to look at this is that depression, anxiety, and psychiatric disorder, those are not the same things. And I don't think it's fair of us to just call the variable mental health. I think one of the things we need to do moving forward with our research is do a much better job of figuring out what this needs. Lumbar column, lordosis, stenosis, these other ones. And what we found was a very strong treatment effect for surgery at 2 years and at 4 years, where average change for baseline from the non-operatives essentially unchanged and pretty close to unchanged. Substantial, because this is a scale of basically 4 points, right? 1 to 5. These are pretty high changes for SRS subscore. ODI is the same thing, greater than 10-point difference between operative and non-operative, both at 2 year and at 4 year. Justin Smith has just written the combined cohort is sustained out to 5 years. So we have reasonably steady, not worsening, but not getting better, non-operative patients. Here's the ODI. This is SRS subscore. Here's the ODI. I think there is some value in this data for our patients because, again, these are the people, they're under 40 with their ODIs, right? And they're petering along and they're not getting worse. They, by and large, don't get better, but they don't get worse. And I think that that's valuable to tell the people. Surgery does sure seem to work, and it seems reasonably stable, despite, as you can probably guess and will see, a fair number of complications and reoperations. So what factors were associated with better outcomes? This was a paper we just published in JNS Spine. People with more pelvic parameter mismatch improved more in the surgical group by about 10 points on the ODI and 0.5 point on the SRS subscore. Not surprisingly, people with worse baseline HRQOL were associated with greater improvement. I don't think this should surprise any of us, and I think this is one of kind of the tricks of using health-related quality of life scores like the SRS and the ODI to assess what we're doing. That if you start with someone that's reasonably high functioning, but maybe they have a little back pain and a progressive deformity and maybe a little bit of leg pain, but their HRQL scores are pretty close to as high as they're going to get, and then you do a T10 to the sacrum or a T3 to the sacrum on them, I don't know how much better you can actually make that person. I don't think getting them to an ODI of 0 or even under 10 is a reasonable goal, and certainly I don't think that getting them to an SRS subscore of 5 is a reasonable option, because I find it hard to believe that anyone would have a function score of 5 after you fuse them, as opposed to people that are really low. It's pretty easy to bump them up the scale. The more remaining scale you have, the easier it is to change. What about, we always look who did worse, but what about we like to look at who does the best. What about the things that we like to blame? The things that, oh, no, that person did poorly because they got bad mental health, or they have low SES, socioeconomic status. This we did by education level and household income. Or no, they're so fat, that's why they did poorly. They seemed in the ASLS analyses to be unrelated. It didn't, when we stratified groups by mental health and those other things that very classically we like to blame, they were not related. And I think that leads into the next point, which is very important, and also important for us as we plan future studies. I think as we write current research papers, and as we review each other's papers, the adjusted and unadjusted 2-year estimates from these models, where is it? They were really close when we did adjusted and unadjusted, really close. Meaning all of these things that we like to measure, BMI, blood pressure, all this stuff, it had very little effect on what the statistical model estimated for their HRQOL at any time point, which I think to me tells me in part the effect of those things that we love talking about at the meetings is very small, and the importance of those is also small. And I think if you critically look at things, you'll see a lot of the times that people focus on p-values in papers, but the odds ratio is like 1.1 to 1.2 p-value less than 0.0001, right? That means essentially nothing, an odds ratio of 1.1. That doesn't mean anything. So you got to be careful when you read that kind of stuff. Adverse events in ASLS. Adverse events related to non-operative care were uncommon. 3 GI bleeds from non-steroidals essentially were the only serious adverse events that we were thought were reasonably related to the treatment. Other than that, SAEs happen because of aging, and you get knee arthritis and hip arthritis, and you fall and you break your wrist, but those were deemed unrelated to the spine surgery. Adverse events related to surgery were common and remain common as we continue to follow these people. We're going to follow them up to 7 years, thanks to the SRS and industry supporting it, because the NIH rejected it. The NIH rejected our renewal because of the non-adherence, and they didn't think that there was value in following these people. Intraoperative complications were 15%. New neurological deficits in these, and I hate to say simple because I'll probably paralyze somebody on Wednesday now and jinx myself, but these relatively simple surgeries were still 10%. There were 4 major Asia-C injuries and 13 minor. One of those patients died. One of the 4 majors died as a direct result of their neurological injury. The patient did not leave the hospital and died from adult symptomatic lumbar scoliosis surgery. And very importantly, reoperations. So there's been 75 surgeries in 54 patients at 5 years, unintended second surgeries. And that's an overall incident rate of 7.5% per year, which may seem small, but we followed those people for 5 years, right? So 8 per year, that's 40 reoperations for 100 patients, 80 reoperations for 200 patients. That's actually becomes a pretty big deal if you look at sort of the incidence rate in a more appropriate way. Like a lot of the times in our literature, first of all, people mess up prevalence and incidence all the time, and they'll just divide the number of operations by the number, divide revisions by number of operations and tell us that that's the incidence. That's not the incidence. And so what are the effects of these reoperations and adverse events? Serious adverse events seem to have a negative effect after surgery. However, one SAE and the patients still do better than the non-operatives. They may have some blunting of their potential HRQOL improvements, but they do seem to do better than if they had not had surgery, is the takeaway. Multiple reoperations, and that's when HRQOL begins to sort of really fall, and the benefits of surgery will be lost. So this is from Justin's 5-year follow-up paper. Those people with 2+ SAEs, you can see here, now this is no different than the non-operative cohort because they're starting to fall. Half of the improvement in the SRS subscore versus someone that's had none. Same thing here. Half of the improvement as to someone who's had none in the ODI. In patients, so this is Andrew Pugley's study that he wrote when he was a fellow, looking at the effect of all-comer serious adverse events in the non-operative group. And Dr. Bridwell said there's much more to it than what you're saying, Mike, but my goal of that paper was just to say what happens to someone who comes to your office and doesn't want surgery or doesn't have surgery, but wants to know what the future holds for them. And so we wanted to look at serious adverse events unrelated to their spinal deformity and the effect of HRQOL. And lo and behold, about 1/3 of them do have some serious adverse event, but those are tracked as anything, like I say, a hip fracture, humerus fracture, joint replacement. And they, on average, have worsening of HRQOL, but my guess is that that's just a function of aging. So how do we interpret ASLS? Non-adherence, quote unquote, ruined the randomized study with nearly equals the numbers of people treated with surgery at 2 years. The treatment effect was so large that even the 1-year intention to treat showed benefit to the surgery. But unfortunately, our primary outcome was 2 years. So we submitted this to the New England Journal of Medicine, and they said, well, you got to fix it. And I wrote with Keith Bridwell like a 35-page response to reviewers. I've never done anything like it in my whole life. And then that came back with a 3-line rejection, just rejected, because no conclusions can be drawn from your study because of the non-adherence. So I think first lesson is when you need to be judicious when embarking on studies of operative versus non-operative care for musculoskeletal pain, particularly in the United States, where people can just go get what they want someplace else. Sport and ASLS were affected by non-adherence. Sport was, if you'll all recall, Sport was published in the New England Journal and in JAMA. And we kind of said that's in the New England Journal, and their response was, times were different then. We're better statistically and methodologically, and the feeling was that they probably would not publish something like Sport now. Moon and Mars are sports medicines studies funded by the National Institutes of Health here that are well-designed observational studies, which I think is closer to what some of what the ISSG is doing now. We have the Complex Adult Deformity Study, CADS, that has an absurd set of questionnaires and data points that you need to collect, but it's observational rather than randomizing. How do you interpret for your patients? On average, surgical treatment works with substantial important improvements in ODI and SRS subscores, which are sustained at 5 years. On average, non-operative care is not associated with improvement, but also not on average associated with worsening, and that is also sustained at 5 years. The adjusted and unadjusted models don't have much difference in the calculated change, so I'm not sure that we're measuring the right things. I think perhaps we focus on some of the wrong things, both in the office and in sort of our academic pursuits. Should we just keep doing the same thing over and over? We kind of like the basis for creating this talk the first time was I went to the American Orthopedic Association meeting right after Sport, and it was a debate. Did the NIH get their money's worth? Because the NIH spent about $10 million on Sport, and there were things like the main lumbar spine study, which were sort of not great design, but not terribly designed for the time. Observational studies where the conclusions were the same. And now we've done ASLS. We spent $3.5 million from the NIH. We have a bunch of industry money now. And what we're saying is our results are not all that different from ISSG or ESSG. Non-operative care is generally safe, and surgery carries risks both of unintended surgeries and serious adverse events, where you really need to weigh the risks and benefits, expected outcomes, and what the patient wants. So that was ASLS. That examined the normal deformities. But what about the exotic deformities, the sort of the trophies we like to show everybody, and the cool cases? So that bred Scully risk. The primary question that led to Scully risk 1, and there's a reason why there's a 1 at the end, is because there was going to be a Scully risk 2. The primary question was, can riluzole act as a neuroprotective agent against new neurological deficits in adult spinal deformity? Michael Failings is a neurosurgeon in Toronto who's a very accomplished spinal cord injury researcher who is very interested in riluzole as a neuroprotective agent. It's a calcium channel blocker that can blunt neuroexcitatory transmission to reduce axonal loss and neuronal loss from the second hit of neurological injury, right? There's 2 hits. There's the one that the actual trauma of whacking the spinal cord, things will die from that. You can't stop that. But there's all the inflammation, and that's the second hit where you get inflammation, apoptosis, and cells talking to the cells next to them, spurring apoptosis all around, and that's what he was trying to block. To plan the RCT, to plan Scully risk 2, you really need to have an accurate estimate of the new neurological deficits. But, so how is Scully risk 1 and ASLS, how are they really not that different? The prior evidence was not that great. There was just numerous retrospective studies, particularly on 3-column osteotomies, on neurological deficits. There is a complete absence of Asia motor scores with lower extremity motor scores, right, scored out of 50 in particular, which is a validated examination to tell you of the neurological state of the patient. And all of these retrospective studies in general said, the rate's around 10%. If you look at Ohana Boboachi's experience, the Bridwell-Lenke study written by Jacob Buchowski and JBJS about pedicle subtraction osteotomies, the reported neurological deficit rate was around 10%. In doing Scully risk, one of the things, and again, this is something as you guys do prospective studies, this is a nice, Larry loves doing this, is to do, while you're doing the prospective study, you look back in time and you do a retrospective study using the inclusion criteria of the study you're doing. So that's what we did. 5 of us participated, where we filled out the data collection sheets for Scully risk 1, going back in time, identifying people that were Scully risk eligible. And what we found, it was us, UVA, WashU, UVA, UCSF, Norton Leatherman, and NYU. 50% had some complication, and there was a 9% identified new neurological deficit rate. These new neurological deficits also seem to be independent of the 3-column osteotomy, which it's also, that's, I think, important in whether or not that's true, but we need to figure that out, because a lot of the times we like to blame the 3-column osteotomy when in fact it could be their spine, and the spine being a setup for disaster because of the problem that they have. This guy had a 3-column osteotomy, but he was a prior trauma with a laminectomy where his conus was stuck to the front of L1 here. And whether or not you do a 3-column osteotomy, manipulating his spine is going to be difficult and be wrought with risk. So what did Scully Risk 1 do? So it was an observational cohort study of high risk. They were looking for the patients most at risk for a new neurological deficit. The inclusion criteria were any major Cobb angle greater than 80 degrees, so it could either be coronal or sagittal plane. Congenital deformities treated with osteotomies. Spinal deformities treated with revision osteotomies. Any 3-column osteotomy, thoracic VCR or lumbar PSO, or anyone with myelopathy due to their spinal deformity or spinal deformity with ossified ligamentum flavum, anything like that, within the thoracolumbar spine. This did not include cervical spondylotic myelopathy patients. Good things about the design, right? 15 centers around the globe. So it's not just North American centers, it's 15 places around the world. I think that adds some to the external validity and probably gives us a very real rate that we can discuss on the podium at the SRS, and all feel very comfortable that the rate that we find is probably accurate of what is real life. The surgeons decided the treatment. There was no guided treatment algorithm. Again, that lends external validity to your study, letting it be an observation of just what real life holds. It's called, in some regard, it's called a pragmatic trial, where rather than trying to randomize, you just do a lot of people, collect the data very carefully, think about the data in advance that you want to collect, and then by measuring so many people, you probably get a real estimate of the true value. What did they find? So, not surprisingly, 23% rate of lower extremity motor score deficit at discharge. Twice, right, which I just told you in this study, twice this rate of 10%. At 6 weeks, they were slightly better. At 6 months, now you're down to the 10% rate. And that is probably why the retrospective studies that we hang our hats on so much, they're probably not wholly inaccurate for the long-term outcomes. They're probably less accurate for patient counseling about, well, this is your risk at discharge and things like that, because we're going to miss minutia, but they're probably good at capturing the very gross differences. And we wrote a paper about that, showing the value of prospective study rather than retrospective study. So the deficits tend to improve. Patients also, they stratified Scully risk according to those that had no deficits and lower extremity motor scores of 50, and those that had some deficit. Even those that had some deficit before surgery got worse after surgery. They also improve relative to their baseline. They don't get to normal by and large. Only 4 patients had real serious neurological deficits where their lower extremity motor score decline was more than 10 points. 2 improved to essentially normal, 2 did not. 1 was lost to follow-up, and then the one that was not lost had a pretty profound change in lower extremity motor score, where patient was probably non-ambulatory. The majority of the deficits in Scully risk seem to be lumbar osteotomy related, rather than thoracic VCR. And I don't think that that's what anyone expected in that series. They expected more neurological deficit rates at the spinal cord level, but it seemed to be a whole lot more with lumbar roots. Evenly divided, as you can see here, L2, L3, L4, L5, S1. And this is something that Dr. Patali and I had talked about with choice of levels for your pedicle subtraction osteotomies. This is an L5 this was a terrible case. She's multiply operated, has a severe sagittal plane deformity because her pelvic incidence is approaching 90. She's got a prior front back for an isthmic spondylo that's a non-union. a TLIF here that's a non-union, a TLIF here. So this is 3, 4, 4, 5, 5, 1 with roots that are all scarred in. And I had to pick my poison of where to do it. I did an L5 PSO, and she woke up with a left foot drop. I'm kicking myself. What could I have done differently? Should I have gone higher? But had I gone higher, leaving someone with a quad drop and knee extensor weakness is far more devastating, I think, than leaving someone with a lower lumbar root deficit. Obviously, you don't want any deficits at all, but I think these data sort of support the idea of going lower to where you're comfortable, because the deficits are not different across the levels, and the deficit up here can leave you non-ambulatory or make walking very difficult. They also collected HRQOL in these studies, and how did it work? Yes, in these very complicated patients, it did work. They don't have subscore on this chart. They have total score, which makes it seem like it didn't work very well. The subscore on average goes from 2.8 to 4.1, which is very high. Physical component summary only went up 6 points, which is not great, but maybe a function of some of their other comorbid conditions or myelopathy. And not surprisingly, again, consistent with basically everything we've done in these studies and outside, the complications tend to have a negative effect on HRQOL, though recoverable complications tend not to harm them quite as much. So what are the Scully risk takeaways? Almost 25% new neurological deficit rate, which was twice historical norms. It's likely a function of prospective study design rather than worse surgeries or surgeons. Half of the people improve, half of them do not improve. Most of the deficits are related to lumbar osteotomies, PSOs in particular. Your patients that wake up with deficits, most of them improve within 6 months, and that's also consistent with cervical spondylotic myelopathy. The 6-month point is really where I tell people, like, maybe you're going to get a little bit better, but this is probably as good as you're going to get. And HRQOL improvements can be expected. And in Scully risk, older patients and complications tended to worsen HRQOL. So we can pause there because this is the other stuff, but I think we have plenty to talk about if you guys would like to talk.
Oh, Mike, if you are still, how can I say, excited, you can keep it. It's outstanding to listen your ideas. What do you prefer? You prefer to stop and we discuss a little bit, or keep going? It's up to you.
Let me see here. I'll show it to you quick because I think it's pretty interesting. It's a combination of what Chris Ames and I and Ferran Police are doing, and then some of the stuff that we're doing here.
No, go ahead. Go ahead.
I'll try not to be. I won't be too long for you. So now the question is, where do we go from here? How are we going to make things better? We can't continue to do the same thing over and over and over again. And this part of the talk comes from both very large, we're at a fork in the road of doing the same thing or doing something different. And then there are two ways that we're going to be able to look at this. We're going to have very, very large amounts of data now as electronic medical records are sort of more ubiquitous and finer tuned, because they are like, I don't know if any of you guys use Epic. Epic is sort of spreading like wildfire here. And Epic is not just designed to be a medical record. It's just like Facebook. It's designed to be a health data capture instrument that will eventually, I'm sure they'll sell it in some form or another to people. So, but the EMR is going to make vast amounts of clinical data readily available. We need to improve the value that we deliver to both patients and society, because spending is unsustainable, particularly in adult spinal deformity. predictive analytics is used extensively in other businesses with great success, and we are slow to adopt, in part because of the difficulty of collecting the data, unlike a Coca-Cola plant or something like that, which can probably collect data a whole lot more easily rather than us. So this is called a Phylogenetic Dendogram. This is from a paper I did with Chris Ames, where we combined the ISSG and the ESSG, and we told the computer, find people that are similar and dissimilar. And the people on the periphery are more dissimilar to the people on the inside. The people that sort of are yellow here and purple here, they are close to the same and more similar, if that makes sense. And what it did was it found young primary, old revision were the basic tenets of what the computer said. These are your clusters of patient types. And once you start doing that, then you can look within here and say, okay, the patient I have in my office, it lives here. What did these people get and how did they do? And once we identify, well, these people got this and they did poorly, or these people did this and we did great, they did great, we can start personalizing care for patients and providing a more customized medicine in adult spinal deformity. Why do we need this? And I alluded it to a little bit earlier, but group risk does not equal individual risk, particularly in spine surgery. Getting relative risks and odd ratios and all that, that's very nice, but that actually doesn't tell you about your patient. And there are profound and frequently misinterpreted limitations of this. So suppose you say odds ratio for a post-op infection in a poorly controlled diabetic is 1.68. The risk of infection for your patient is not 68% higher than some other patient that's not a poorly controlled diabetic in your practice. How can we put this in more usable terms for the patient? How can we get their expectations set in line to affect their ultimate outcome by HRQOL also? So other predictive analytics things we've done. So this was clustering for risk stratification. We have done predictive analytics to see who is most likely to achieve MCID or greater changes versus who is not. I think even better than that is we can try to predict, and with some accuracy, what their individual score changes are going to be for the SRS, which puts all of this, like if you tell somebody your ODI score is going to change 12 points, that doesn't mean anything to them. But if you say, well, you know what, people in your situation that had this surgery who said, I can only walk a block because of my back pain, and then said, I can walk a mile because of and then I'm limited because of my back pain. There's 40% of people that get there. That changes the ballgame for their understanding of what we're doing. We did prediction for cost and prediction for complications also. So a larger look at this. So this was development of deployable models because we have an online tool that we can use where we can punch in the data and figure out who's going to do the best. The way you do, or the way we did these predictive analytics, was use 8 different prediction algorithms, some sort of linear standard regressions and other nonlinear, fancier, I like to call it, regression models. We put everything in for the most part. It's a little short of everything, but put everything in and let the computer pick out what it wants with 3 time horizons, baseline 1 year, baseline a 2 year. And then you can also look at the importance of the variables within the algorithms. And again, back to what I talked about before, how baseline health-related quality of life really affects how much you're going to change. So these, which are really driving the change, it's not really fair to look at those. Age seems to be important, level of physical activity, but they're reasonably small contribution to it, which goes back to the, are we even measuring the right thing? I think one of the things you'll see, like major curve, doesn't really matter, sagittal balance, baseline, they're not as important as we like to talk about. This is the output. This is beyond explaining here, but this is how you do it. So the theoretical patient, a 60-year-old woman, 1 prior spine surgery, no comorbidities, she's got a job, she's plus 7 centimeters, she's got high pelvic tilt compensating for her lumbar lordosis PI mismatch, and then the surgery you're proposing is 10 level, all posterior, single PSO, put in iliac screws, no interbody fusions. And you can say, well, here's the likelihood your baseline ODI is at 68, 50% chance you get better to an MCID. What about, and then this is what's beneficial for patients. What if we wait 5 years, you get 10% worse in your ODI? Well, you're more likely to improve MCID. What if we wait 10 years and you get worse? What if we change your SVA? And what you see here is that these are generally the same, because the SVA didn't seem to play out all that important, which again, for HRQOL versus things like the idea of the gap score, I think that maybe we're mixing concepts. But this gives you a usable template or sheet that you can go over with the patient to explain, well, this is the likelihood. You know, if they say, I don't care what I look like, you don't need to worry about, you can't like go and say, well, you're almost certainly to like how you look, but it's 50-50 on whether or not you get pain improvement. They might say, well, I don't care what I look like. I want my pain to get better, and I want better than 50-50. So this will help with the shared decision-making process. And as I just said, so the other thing is, I think it's probably an easier way to explain improvement to patients if you can come up with discrete concepts of, this is where you're going to be able to walk. This is the activities you're going to be able to do. Which you can do by answering or showing predictions for the individual questions on whichever outcomes questionnaire you choose. And I think that setting expectations is really essential to achieving good outcomes and having happy patients. MCID be damned. One of the papers, it was rejected. I'm really disappointed it was rejected by the SRS, but I found there's something called the decision regret scale. It's a validated instrument about decision regret that's been investigated in also breast cancer, general surgery, all sorts of things, but never in spine surgery. So I did it on anyone who came here that was at least 2 years out from their surgeries, included prior patients or patients new to me. The number of people that didn't improve with HRQOL, didn't meet MCID, particularly for things like pain, had multiple surgeries, multiple revision surgeries, was astronomical. Essentially, none of them had any decision regret. They all said, I would do the same thing again, which maybe means we're not, again, capturing the right stuff with the SRS or the ODI, I'm not sure, but that it just weighs into the psychological effects of the decision to have surgery and the cognitive dissonance that probably exists to some extent for these people that say, there's no way, you know, I know I'm not better, but there's no way I made the wrong choice, because they can't accept that. So some of the potential priorities in predictive analytics, patient-reported outcomes and costs, those are the two to help drive value. It's important both to identify those that are most likely to do well as those likely to do poorly. I think too many times emphasis is put on doing those finding those most likely to do poorly, kind of like Rajiv Sethi's stuff in Seattle. He really harps on, we found the poor and sucked them out. We found those doing poorly and sucked them out, but little emphasis on really identifying those likely to do the best. And now, so that's the sort of the mile high, very large numbers of patients with huge amounts of data. The stuff we're working on now at WashU, I finally have some money to do this. And I started this back when I did that retrospective Scully risk study, because I did the retrospective Scully risk study. And what it seemed like was patients very globally fell into a bucket of, I did okay, or holy cannoli, I did really poorly. And I had a lot of complications, and I had reoperations, and my hospital stays were long, and my HRQOL tended not to go up nearly as high as these people, which just struck me as two different sets of people. So what we're investigating is the immunophenotype of surgery. So the first thing we need to answer is, what is the effect of surgery on the immune system? And then how do the different immune systems respond, and how might that relate to outcomes or complications or recovery, or ideally I want it to be all of the above. So you guys should all review this study. If you email me, I can send you the PDF. Brees is an intensivist at Stanford. And these guys, Bill Maloney is the chairman at Stanford, Huddleston, Stu Goodman, they do joint replacement at Stanford. Brees took their patient's blood and found that there was a distinct immune signature for those patients that did really well after a total hip, recovered quickly, and those who recovered slowly, and found that there was a difference in the way their immune system responds. Using this device this is called the time of flight mass cytometry, which allows you to study thousands and thousands of events inside the cells It's sort of the blend between mass spectroscopy and flow cytometry. My goal is to develop a preoperative test so that we can determine whether or not people are ready for surgery and primed to do well, or if they're not going to do well. And then the follow-on thing from that would be to figure out what we need to do to them. Is it a perioperative pharmaceutical that they need? Do they just need to get in better shape? Do they just need to lose some weight and get some fat off and not have so much leptin floating around, whatever it is? So how are we going to study this here? What am I going to do? I don't have it in here, but we've completed it on, we did 13 adult spinal deformity patients with the immunophenotyping, and there's a distinct signature of surgery. And when you put it on a graph, it's unique to surgery, as opposed to when you put it on a graph, we can put it on, surgery patients fall here. Septic, critically ill septic patients are up here. Non-critically ill septic patients are over here. So the immune system is responding to all of these stresses differently. And then now, because we're in the time of COVID, you'll all find it interesting too, that we all know that COVID has a very different response to totally asymptomatic, to I felt a little sick, to I had the flu for a couple days, to it's a train wreck and potentially dying on a ventilator. When we put COVID patients on this graph, they were all over the place. Some behaving like critically ill non-septic, some behaving like critically ill septic, some behaving like they just got a big old surgery, and maybe those are the patients that are knocked down for a week and get better, and then some not even falling into any of those categories, and perhaps those are the ones that recover fastest. What are we going to do here? Our anesthesia service likes to use IV lidocaine as a perioperative non-opioid method of pain control. We don't really know how it works, right? You know how it works as a local anesthetic, but when you give it IV, it's not working through the same mechanism, because you would have, there's an inadequate volume to actually block anything in any substantial number, and you'd probably have cardiac effects if it was that high. What we do know is that it directly affects the actions of peripheral mononuclear cells, macrophages, monophages. It attenuates TNF-alpha and interferon gamma release after a lung injury, decreases TNF-alpha, IL-6, and IL-8 in settings of endotoxemia. This picture here is former Grant, and this is why WashU was cool. This is one of the professors who is NIH Order of Merit, Richard Hotchkiss. He was looking at what we were doing and said, you guys need, you need some pictures, you need some data. He drew his own blood on a Wednesday, isolated his white cells, treated his own white cells with varying concentrations of lidocaine, and showed that there's a dose response difference from interferon gamma and TNF-alpha expression in his own white cells. Very cool. So we're going to do IV lidocaine randomized trial in AIS patients, where they'll either get placebo or IV lidocaine. And what will that do is, so that, first of all, the first thing is it'll tell us if IV lidocaine is something we should be exploring, and potentially in the adults. The placebo cohort is going to give us a very nice picture of what the immunophenotype or immune signature of surgery is in a very clean, naive immune system. These are 12 to 16-year-olds who don't have a bunch of comorbidity. They don't have hypertension. Some of them are obese, but they're not like my adult practice. They don't have diabetes by and large. All these things that happen to adults that hasn't happened to any of the kids yet. So I think the placebo cohort will provide us very nice data about what the surgery does. And then the investigational arm that gets lidocaine is going to give us a very nice picture of how lidocaine works. And if we can figure out how it works, maybe we can find a better downstream way to intervene rather than giving them lidocaine and sort of not knowing what it's doing. If we can find some downstream pharmaceutical to treat as a non-opioid pain control, that would be very important. The Guadalari paper is prelim data supporting the concept of this relating to recovery from total hip arthroplasty. In both adult and pediatric spine surgery, I think the sterile trauma from spine surgery is so much greater than any total joint that I think we have a really nice sterile human model already for sterile trauma. This is lots of blood loss, lots of muscle damage, lots of expression of damaged associated molecular patterns, which are these sort of extrinsic pathway to inflammation in the body, like myosin and mitochondrial DNA. And adult spinal deformity is really where I want to go with this, because the recovery is prolonged, as you saw from the curves in both ASLS and Scully risk, that around 6 months, they're close to better, and it's really 12 months where the HRQOLs are better and they're recovered. So here's, in conclusion, right? Adult spinal deformity, operative treatment seems to work. It comes with the risk of adverse events, including reoperations. All of these treatment modalities are expensive, and we need to maximize improvements and optimize expenses. We don't need to minimize expenses. You need to optimize expenses. I think predictive analytics can assist in all areas of the value-based delivery system, both in terms of cost and optimizing your intervention and optimizing your patient selection and outcomes, and also modifying patient expectations a bit. But I think that personalized care in spine surgery will need both sort of attacking the mental side and the patient expectation side, as well as attacking that very, very granular data where we need stuff beyond chronological age, SVA, ODI, lumbar cob, coronal cob, all these things that are very easily captured by us to write about, but seem to actually not have any great effect or importance in terms of the outcomes for the patients that we treat. So chronological age and biological age is an interesting thing that both Chris Ames and I are working on. And again, if you guys email me, I can send you, there's a calculator for biological age by a PhD, Morgan Levine at Yale. She does some very interesting stuff, and it's the whole concept of, you've all seen it, right? You've seen the 80-year-old in your clinic where you're like, I can do a PSO on them, they're gonna do fine. Look at them, they're 80, but they look 60, they're spry, they're sharp. She's walking, 2 miles a day. And then we've all seen the 50-year-old that you're like, oh my God, this person looks terrible, they're gonna do terribly. And it's the idea of the damage to the DNA and cellular changes that happen with all of that sort of abuse that comes with inflammation, and not necessarily chronological age. Chronological age is probably something we should be getting away from. All right. That's it.
Very good, Mike. Very good. Very good. So let's see. Any questions, guys? I have some comments, and there is any questions? Yes, Gabriel. Gabriel, I'll do my comment, and then if you want, you can we can open to you. If you prefer, Gabriel, you can ask directly to Mike. So, Mike, I have a few comments. I took note here. First, I totally agree with you that in terms of surgical complications, one of that we must have more afraid is the neurologic deficit. And in my practice, also, what I saw is it's more common lumbar roots deficits than spinal cord deficits. Do you think that maybe the MIP not so sensitive for roots may be a cause? Have you thought about any cause? Because it's surprisingly, but in the practice of many surgeons, we do the same. We see the same.
It's too bad Hanjo or Larry's not here, because Hanjo and Larry believe in MEPs for the roots. I've talked about it with Ames and Calcabesh. We think they're terrible. The false negative for transcranials for root level deficits with our modalities, and in Chris Ames's experience and Cal's experience, is not good. Larry and Hanjo think that they have some algorithm with some particular anesthesia protocol that makes it very sensitive. Obviously, like Larry left here and he took one of our neuromonitoring guys, and he remains very good friends with the neuromonitoring staff that stayed. So I had them call him and talk to him, get his protocol. I want to try this. And one of the things that they were doing is looking at the quality of the spikes after the transcranial stimulus. So I had them put a program on our computer, and I said, and they were saying, well, oh, you got to look at it. Bullshit, look at the predictive analytics stuff, right? There's no way your eyeball is better than a computer. So we put a program on that measures the area under the curve of the transcranial spike so that we can identify any changes in that spike. And the last time we looked even at using this area under the curve analysis, it just doesn't seem to work. You know, neurological deficits, my experience for PSOs is that they are by and large my fault. I can think of one. I did an L4 PSO where I did a big correction, quad weakness went back, and there was a little bit of bone on the L3 nerve root. That really bad one I showed you with the T-lifts everywhere and the spondy non-union, the roots were all scarred in. We were trying to skeletonize the L4 pedicle, and I hit the root, the leg jumped, and that was ball game. It's my fault. I think that and that's the problem with practice of medicine, right? So I did things in those cases that case, I recall, I mean, I obviously, just like you guys, probably remember all my complications distinctly. It was bleeding a lot, and I was like, look, we just got to move. We got to get going. She's going to lose a lot of blood. And what I should have done is said, it's bleeding a lot. We need to stop and get this bleeding under control and make this spotless. And then maybe I wouldn't have dinged the root. But I think a lot of the times in my experience, the lower lumbar root complications that are real are my fault. And hopefully that comes with time. But like you said, I don't think there's any great way other than feeling the roots. That's what I do. I think you feel the roots. Are they free? Is there no bone around it? You know, Larry, the way Lenke taught me, and if you guys look at the JBJS paper that Bridwell wrote about his PSO technique, have you seen it?
Yeah.
He's got this unbelievable artwork where he's got this hole right where the roots are. I don't know how to do it. There's a hole in the lamina, but the pars still come together and are in contact, and he feels in this window. First, that reduces the amount of angular correction you can get. So the historical correction rate's like 20, 25 degrees, which a lot of times is not enough. You need 30, 35, 40 degrees. You can't get it when you leave. But you leave all that dorsal bone, and that's how you start getting neurological deficits. And when Gupta came, and Gupta goes, if you do an L4 PSO, he does the caudal pedicle of L3 to the top of the pedicle of L5, everything's gone. And the first time I saw it, I was like, this guy's out of his mind. What is he doing? He's going to get non-unions. But when you do that, one, all those roots are free. So you're not going to you get some, right? Just like you said, things where you just didn't know, and maybe there's some scar out there, but you're not going to have an iatrogenic sort of compressive lesion when you do that. And he gets huge corrections. So then I adopted that.
Yes, I totally agree.
Sorry.
Second point, you said
this too much. I think we have a question from somebody from the audience, Fabio. Fabio,
yep.
You have permission to talk, so you can do your question direct to Dr. Kelly.
All right. Hi, Dr. Kelly. My name is Fabio.
Fabio.
Yep. First of all, I would like to congratulate you about your presentation, and I'd like to know if about your first study, right? So I'd like to know if in the operative group you had all the patients were underwent arthrodesis, or in some case they had just decompression alone, right? And if you compare these different types of surgeries and you had different outcomes.
So everyone in that study underwent an instrumented spine fusion.
Yeah, because sometimes we feel that we are pushing the bar, right? We feel that we like to treat the X-ray instead of treating the symptoms. I had this question. We discussed this a lot. If you are treating the X-ray, right?
Yeah.
Instead of treating the symptoms, and we discussed this with our colleagues. Some of them just they correct deformity. They don't perform any type of decompression because they feel that when you correct the spine, the patient will be better without any type of decompression.
Yeah, well, that's certainly not true. I think everyone knows that. And it's the approach to it is multifactorial. Like I said in the talk, James Kang at the Brigham, he was pretty aggressive with even deformities of doing really wide laminectomies, huge foraminotomies, exposing out to the TPs like he's doing a fusion. not putting any screws in, grinding all that lamina up and putting it all and doing a non-instrument infusion. And probably a lot of sort of pseudarthroses, but he says it stiffens the spine and it gets rid of their leg pain. That's one thing that I don't think we really know if that in the long run is better. And then to your point about, I think if we're going to instrument, and that's why this is when like we need to figure out, all of us that continue to do research, we need to figure out what the right alignment is. So you to the extent that you're not treating the x-ray, you got to treat the x-ray based upon, I still believe, based upon their pelvic incidence and what their global sagittal alignment should be. I believe that when you fix people flat, I believe the gap score stuff from JBJS, Charlar's paper that says, and if you think about it, you know, I love Charlar, but I don't love that paper in part because now they're like really, The idea is that if you don't treat the x-ray to the extent of getting their lordosis right, and they stand with a false type 2 Russelli profile, right, where they have pelvic retroversion, they have fused spine, but they still have some retroversion. That fusion's going backwards, but they're still forward, and everything's going forward. And then you get tension, and I think that's how you get PJK and pseudos to some extent. So I think that to treat the x-rays and be a real deformity surgeon is just, I think it's right in some regard, but I don't think that just treating the deformity, no way. It's because, especially now, suppose you have a patient that's going to get a 40-degree correction, right? They have a relatively stiff, you know, degenerative flat back, but you're going to swoon them in and make it right. And maybe they don't even have leg pain, right? Maybe they just have back pain from their degenerative flat back, but you get that CT scan, and at every level, they got these little hooks on the medial facets in their lateral recess that are currently asymptomatic because they're flexed. But you crank them back, and then all of those traversing roots get draped into those medial facets, and maybe not all the time they become symptomatic, but in some cases they're going to become symptomatic. So when they have those little hooks, I always decompress them, and not never, always. I always want to at least get those little hooks out of there if you're making lordosis.
All right, thank you. Thanks for asking.
Thanks.
Thank you, Fabio. I think we have one more question in the Q&A. I think there's
about PGK.
Yeah, about PGK. And Gabriel make a question, but I think it's just too complicated to me to translate that. So probably he can do by himself. You wanna go, Gabriel?
Okay, I'm gonna go by here. Hi, Dr. Michael Kelly. That was a very great talk. And at the final part where you say you want to study how the immune system responds to the surgery, I got curious to know if you think that in the future, the spine surgery field will go as other fields to the genome-wide research. So we are starting to use NGS to verify nutrigenomics and other aspects of the patients. Do you think that this revolution will go to the spine surgery someday?
I think there's no question. I think it's just a matter of how fast we can get us there. I really believe that there's something to this idea of the immunophenotype where we should be able to swab them or maybe draw their blood, isolate the white cells and stimulate them in a lab and see if someone's going to do okay or not. And then if they're not going to do okay, how do we optimize them? Chris Ames is doing one now where he's trying to get bone marrow before surgery and look at their osteoblasts to see, are these people that are even going to make bone, and or is this someone that I could put, you know, a Bridwellian amount of BMP in and they're not going to make bone because it's sort of the biological age of the osteoblasts or the mesenchymal stem cells. I think all of that's in the future. I think at some point we'll be able to get stem cells to actually work. I don't know, hopefully they don't sell you all this crap in Brazil, but up here they try and sell us all these stem cells and all this garbage that doesn't work or do anything. But I think at some point you'll be able to suck out a little blood, get some stem cells from it, you know, maybe some iliac crest, and really create a personalized protocol for that patient in the operating room.
Okay, thank you.
I have a question, but I think we have a question from the audience before, so I'll put the question and I do my question after that. Marco Aurelio is asking about when you do a deform correction, if you predict a PJK based on the parameters, if you do something to avoid that or to have a strategy to try to avoid the occurrence of the PJK.
So I actually am one of the few guys still in ISSG. I don't use tethers. My PJK prevention strategy is preoperative alignment targets, and I think choosing the right UIV. My practice is fairly complicated, lots of pretty crazy surgeries, and I think I have a very low PJK rate. I don't have one of these rates of like 20% of my patients coming back for PJK like the historical things. The two I can think of in my mind were PJKs that came because I said, maybe we can stop here. And I had chosen probably the right UIV in the clinic. And then I was like, let's see if this will probably work. And that was one of the lessons, is stop changing intra-op. Even if it's T1 to the sacrum, that's what you got to do. I think using the ideas of gap. So I use I want to put people back in their cone of economy. I want no pelvic retroversion or close to no pelvic retroversion with the lumbar lordosis that allows for that. And then I choose the UIV based upon how much lordosis they're going to get. So the Russelli 1s and 2s, pelvic incidence 55 or lower, those people, even if they have a kyphotic thoracic spine, I'll give them a shot at T10, because usually when you're bending the rods in, it's a little bit kyphotic already. It's not like you're launching them off, one of those people where the spine goes like this and then the rest of it goes like that. You can tell that those are going to fail before they leave the hospital. So low PI, I will do T10 or T11 for the UIV. And then high PI, I've sort of gotten with the program and bite the bullet and go to the upper thoracic spine, even if there's no deformity, because I believe the concept of them creating this reciprocal kyphosis. And I try really hard to not make the false type 2 profile, which would, in my practice now, would probably be a result of not planning appropriately and planning the right surgery. So that if someone needs a PSO or someone needs a front back, I'm much more aggressive with doing that now than I had in the past. In part because I'm a very lucky guy. I trained at UCSF. I saw Sig and Serena operate, and then I operated with Keith Bridwell and Larry Lenke for a number of years here, and now I have Gupta. I've seen a lot of perspectives on how to do things. Gupta's reoperation rate is incredible. It's so low. He does massive waxed surgery to people up front, has long hospital stays, but he gives them all that lordosis, and his reoperation rate is lower than Keith and Larry's. It's really amazing, with very little BMP. And I think for all of us, the young guys trying to come up in the spinal deformity world, I think it's up to us to figure out how to do less invasive front backs, which I know all of us, or you guys particularly, are doing. Try to do that stuff less invasive to get intercolumn restoration, but not with the big shark bite and not with a 6-hour, front back. If you can do 4-5-5-1 and fill up a couple other ones real quickly and make the lordosis, I think that's what we got to do. So my prevention strategy is really trying to get them back into cone of economy and picking the right UIV based upon both what I think their profile will look like and then what the preoperative alignment looks like.
As you didn't mention braces and whatever else, probably you believe that PJK is something that is not manageable after surgery if you did the wrong type of surgery, right?
Yeah, I don't brace them. The guys at Mayo put them in TLSO with a cervical collar because they say, oh, there's the internal gyroscope and they all want to go forward. I definitely had the patients that come in and say I'm just so used to being forward, and you got to sort of talk to them. I tell them to get a walker and stand in the walker like it's a phone booth. I don't brace them. Do you brace them?
No, I don't think so. I think the PJK is just the body mass trying to find the balance after surgery. And if you did it wrong, it's going to happen anyway. So.
Yeah.
Okay, I have a question about the database collection. Actually, you mentioned about analytics and all the phylogenetic dendrograms. There's a fancy name. I don't know exactly what this means, but I know there's a lot of learning coming to the medicine right now that's come from the BI technology and how people understand customers' behavior and internet analysis and how people, browse. and all of those analytics, they come from a lot of data analysis. So it's a huge amount of data collected, put together, and put this kind of robots processing data and finding most of the time unique solutions, because they're combining things they're not usually put together. Like, you know, why diapers needs to be at the market with the beers on Wednesdays, something like that. And there's a lot of limitation to collect data in medicine, because, you know, the amount of money we spend on data collection, and also there's a lot of ethic points that we have to take place and have concern about. How you think we can manage those limitations on data collection, and how we can automatize the data collection for the future to have a more robust data analysis and nutrition intelligence?
Yeah, that's actually very astute, because I think one of the problems, I don't really know how good the ISSG, don't repeat this, ISSG, ESSG stuff is, because that N is still quite small. Even with a couple thousand people in it, like you said, you really need tens of thousands of data points to do real machine learning at the diapers near the beer level. And with not this many, it's not that good. I think the future really is going to be the EMR doing it. Because I don't think it's going to be that far off when the EMR is going to get that X-ray uploaded, and the machine is going to know how to measure all the angles, and it's going to know everything about that patient. I don't think that that's that far away, and all of that data will exist somehow in the computer. And then these things like Epic and Google Health will start collecting data on such a grand scale. Like, do you guys have Epic yet? Because if you don't, you will at some point. It's going to be just like Google. That they're going to be collecting data on such a grand scale, and then either it'll be Epic with, you know, insurance companies, or Epic with getting together with like this Berkshire Hathaway thing, or getting with the professional societies. You know, if our leaders in the professional societies are able to leverage them to get that data out and use it to better our care. But I think realistically, I don't think there's any way that like we could each say like, all right, come on guys, we got to do a better job collecting this, and we got to collect this on 10,000 patients in the next 8 years. I don't think that's going to happen. I think it needs to be at the EMR level.
And most of the time, you're just collecting data on the part of the patient that matters, you know, for the surgery or
Exactly.
whatever.
Yeah.
And integrating all the points, you know, habits, how people, you know, sleeping time, cycles, and whatever. I think if you able to collect data from like smartwatches and the way, you know, the activities, and more than just, you know, objective data.
Yep. More important stuff, I think, like more important than the Cobb angle and things like that. But we don't capture that because it's too hard.
Yeah, yeah. That's the point. We need to integrate this type of data collection and put together.
So, Mike, the first time I've watched Dr. Ames presenting, and then I read the study about the artificial intelligence analysis to predict risk and to split the groups. And now seeing you present, I had the opportunity to talk this with Virginia Lafarge, and it's for me, and I would like to know about how you think. The impression is we stay like the last 20 years or more talking about numbers, thresholds, classifications. And then we start to see that maybe the patient status, and as you mentioned it, and I totally agree, the outcome expectation probably is most important than the numbers. And now you come with adding the phenotype analysis. So in the future, what do you expect for the adult spine deformity planning? How to talk, how to create the correct expectations for the patient, not for the surgeon, but for the patient, taking all of these concepts in mind?
Well, I think, I think probably getting a better idea of how to counsel them on real expectations, putting them in terms that they can understand. That's going to be number one, followed by counseling them about this is going to be a risk of more surgery. This is going to be a risk of a bad complication that's going to lay you up in the hospital. But what we know is that you're probably, if you recover from this, it's not a big deal, but I want you to know to provide, but again, number one, I think really gets to the heart of the personalized or customized care to meet their goals for outcomes, HRQOL. I think that some of what Chris is doing as you analyze the responses to particular scores will be helpful, but I don't even know that that's enough. I'm curious what Virginie said, because this whole decision regret thing kind of throws it all out the window. Some of these people did terribly, and they just said, well, I'll do it again. And it's, what is wrong with you? You did shitty, and you're going to do it again? Why you want to do it again? So they have this belief of the success that's just waiting for them with surgery. So I think, but I think probably the future has got to do with answering the questions on the scores so that you can put it into real terms. And maybe even before you do that, probably the most appropriate is asking them, what do you want? Because if you come in and you start saying, oh, yeah, your self-image is going to be better. Well, I don't really care about that. Oh, yeah, you're all hunched over. You could very easily sell something on to someone who actually, had you had them fill it out in the pre-op holding area where they said, I don't care how hunched over I am. My leg's killing me and I want my leg to stop hurting. They need to define it in advance. I don't know if Virginie brought up the patient-generated index paper. There was one that Ames did. It was very complicated. And it was like, you had to like hold the patient's hand because the questionnaire was so complex. But it basically had them assign weights to what they wanted was important and had them fill out what their goals were. I don't know that we can get to a point like that, but probably having better information for us to give them about what we can do, and probably being less of technicians where we say, okay, here's your x-rays, this is what I'm going to do to you. And being more physicians and saying, what bothers you? What do you want? And then it will go from there. I think perhaps we probably need to do a better job interviewing the patients. What do you think?
No, I agree. I remember you mentioned about one patient that I suppose it was you told me that one patient you did a PSO and he had a foot drop, but he was very happy because he could stay upright on the window and can see by the window and can feel the wind in the face. Wasn't your patient?
Yeah, as a neuroblastoma patient that had a whole bunch of radiation. So I knew he was going to get a deficit and did L5 VCR. And I was devastated. He didn't care. I have like 3 people who have evaluated me on like Google, on health grades. And one of them's him. He's happy as a clam. And so again, like how do you come into is that a success? Depends. If you put that patient in Scully risk, my lower extremity motor score went down 5 points. I'm a bum. Patient satisfaction is extremely high. Decision regret score is probably 0.
And maybe even with when the X-ray is not so good for the surgeon, the patient is doing well.
Yeah, I think that's when it starts becoming like we have multiple silos. I think that what we need to figure out is how much does alignment actually matter. And I currently believe, based upon mostly seeing Gupta's results, to be honest with you, that alignment matters a lot. And that leaving people sort of with a LLPI mismatch of 20 or even 10 in some cases is not good alignment. And I don't want to let myself start thinking like, oh no, they're doing fine. I have some partners that do that frequently. And when I talk to the fellows, they say, oh yeah, those patients, like, they have a fair number of people that PJK like this. You know, not like this, over the years. They slowly go forward, and then they have back pain, and then they just get, oh, you know, you're doing fine, you're doing fine. And I'm curious as to whether, by good alignment, we can prevent those or make those last longer. So it's the malalignment that does not result in a PJF or a pseudo, but perhaps robs that patient of some HRQOL. So I'm not sure yet how perfect the alignment needs to be. And so currently I'm trying to make it perfect.
So Mike, I have a question.
Uh-huh.
You're talking about your like alignment goals, and you mentioned that you don't like the idea of age thresholds. So if I understand you right, you always go for like the perfect alignment in your surgeries. And why you don't believe that with age you're going to be a little bit more leaning from in the front? So what do you think about that?
I think it comes back to the idea of whether or not you're going to have tension in the dorsal elements. So a fused, instrumented fused spine is totally different than a degenerated spine. It's a different biomechanical beast, and this is kind of what Ferran and Ahmet will say if you ever talk to them about it, that it's a different biomechanical beast. And I think that fusing someone, perhaps, Keith Bridwell tried to fix people just as they were, and he had very strict selection criteria. So I think that maybe if you don't want to realign them and you want to leave them as is, you have to truly leave them as is and not change it at all, so that they stand with maximized pelvic retroversion in a spine that was just like it was when it came in. And Keith, he was unbelievable at putting them on the table, and he, you know, leave the screws up this far out of the pedicle so that nothing would move. The kiss of death, I think, is when you realign them a little bit to the age-adjusted alignment target, and then they so now, like, can you picture that? I haven't had time to like make a cartoon on PowerPoint with it, but if a T10 to the sacrum that's undercorrected by 20 degrees, right, because they're 67 years old. Now they retrovert their pelvis, but they're forward. So their head's forward, and the head or the C7 plumb now falls between the pelvis and the sacrum, right, because the sacrum's retroverted. But they're trying to go forward. The dorsal elements are all in tension trying to go forward, and as they go forward, the only thing they can do to try and compensate is retrovert their pelvis more, and that takes that fusion mass even more dorsal, as they're going this way, right? And it's a war of attrition. It's going to lead to one of four things: an okay outcome, which maybe it happens more than half the time, an okay outcome where they slowly PJK and they have a little bit of back pain, and we don't know if we're robbing them of outcomes, or they'll pseudo, or they'll PJK. And it's this sort of the predominance of, well, they did okay, I think I did a good job, that I think is making us sort of fail to consider the way that we could potentially improve these. Does that make sense? I just don't I don't like active pelvic retroversion with a fused spine, particularly for the pelvis.
Mike, I have seen some of those patients that, you know, they fuse to the sacrum, and then the patient starts to do a toggling into the sacrum cancellous bone, or even a pull out. And the patient usually goes, like you mentioned, the pelvic shift, changes a lot, to bring the pelvis back posterior to try to compensate that, and then you just fall forward. So completely agree with you.
Yeah, Gupta's results are pretty remarkable for getting get the pelvis, get the hips underneath the sacrum. I don't know if you guys have logged on to any of the Seattle spine guys webinar things that they do now on Tuesday nights and Fridays, but I brought it up one night, and one of the old guys who worked with Art Steffi, right? Steffi is I think he's dead. He is really old. Steffi used to talk about the same stuff, but he didn't understand PI and he didn't understand LL. All he knew was that he was trying to get the hip joints back closer to the sacrum on the lateral x-ray. That was his goal. And so even look at that, 50 years ago, we haven't made that much progress. We know the numbers and stuff like that, but we're still talking about the same stuff.
Feeling. Probably is the final question. I don't know if anybody there's another question, but it's just a summarization of, we did a sequence of webinars, like 4.0 medicine and how spine surgery will be affected by the 4.0 generation. And for me, the summarization of the whole program was just the artificial intelligence going to change the way we analyze patients, because we're going to be able to compare patients instead of using the normal curve with specific subjects, or compare apples to apples. So this probably can change the way we analyze risks and we predict results, but also the incorporation of all the technologies like robotics, navigation, biologic, the better understanding of the measurements itself will make the average surgeon more comparable. Instead of having a very high skill surgeon and a bad surgeon, we're probably going to bring this population a little higher and make a more homogeneous type of surgeon, not surgery. Of course, will affect the surgery as well. So what do you think about that? The incorporation of this technology for you is something that can change the ability of the surgeons and make like better surgeons?
Yeah, I think that's one of the important things, particularly for adult spinal deformity, given the variety of care you can get, is standardizing care. Some people go into spine up here, the residents and fellows, because they say, oh, there's so much you can do. I think that that's a sign of a lack of knowledge, that we should be able to more standardize things and make things more similar. And then the technology, I agree completely. I mean, I think at some point everyone's going to get an EOS and the computer's going to know what their post-op alignment should be. But right now we don't even know. And then you're going to get a custom rod, right? That's going to go in, and the robot's going to be able to put the tulip heads in the right place. And perhaps if they need a lot of lordosis, you just put in some 65mm screws and contour the rod less to make the rod stronger. But right now we don't even know what the customized rod is, because if, you know, as Murillo was saying, so if you put me and Femi Protopsaltis in a room and say, customize the rod, mine's going to look like this, and he loves age adjusted. And that's a huge difference. But I think once we sort of figure out where things need to be, I agree wholeheartedly. I don't use the robot now. I don't know if you guys use the robot. At WashU, like the neurosurgeons went crazy that they wanted the Globus robot. Currently, the Globus robot is in the penalty box because it malpositioned so many screws. And the Medtronic one is every now and again sort of frame shifted them over, which doesn't happen in my hands. So I haven't adopted the robot yet, but I believe that whatever generation of the robot doesn't make mistakes, absolutely, 100% is going to take over for us. And it's going to do it better. Go ahead.
I'm so sorry. I would say just, I don't believe the robot so far is able to create value to the surgery. So far, probably in the future, something it will improve and make it more reliable and more valuable. But I think you're right. I think there's the integration of the whole thing will make a more standard type of surgery. Yeah. Now we have to consider, you know, the art and the feeling of the surgeon as part of the game, and this is not science.
Right. Yeah, the art is probably not here for much longer. Hopefully, like realistically, hopefully not in our careers. Hopefully by the time we're all professors and at the, you know, we're in charge in our departments, that it's a totally different ballgame. And I tell the residents now, like, they're going to laugh when I'm like, you know, we used to do this with our hands and our eyeballs. And I'm like, listen to this old crazy man.
Hi, Mike.
Hello.
Hello, how are you? This is my son, one of three.
Oh my God. Hey, I have two right now. It's crazy. Total
yeah. Chaos. I have 3 boys.
Oh my God. Good luck.
Thank
Okay, I think that's it. Any additional comments?
There is one question from the Q&A, I think.
I think it's another one from Gabriel. Yeah. Gabriel, do you want to ask? Alive?
It's about the promise, right, Gabriel?
Yes, it's about what Dr. Michael think of the capabilities of promise to substitute our PRO questionnaire that we have nowadays.
I think it's great. I was very skeptical at first. What I didn't think was that it was because, and I have always thought of promise as a general measure of health. And I talked to Daryl Brodke at the University of Utah, and they were one of the first places in the States to adopt it in orthopedics. And he said, don't think of it that way either. Like SF36, right, is a general measure of health. He said, think of it as domain specific. So it's not a general measure of health, and it's not disease specific. It's domain specific. And I thought that it was going to stink at finding, at having responsiveness to change, which is the key. What you'll see a lot of our colleagues write papers on is it correlates to SRS, correlates this. That means nothing. That doesn't mean anything. What matters if you're going to use this in your office is responsiveness to change. You started here, I did something, and you finished here. And I want to see that changed. The responsiveness to change of the promise measures when I looked at the adult deformity patients here was excellent. And why does that matter? Because on average, they answer 4 to 6 questions per domain. So you can do pain and function in 8 to 12 questions on a computer adaptive test on an iPad. They don't need to sit there and go through the SRS-22R and the ODI and all that stuff. And I think that we collect SRS-22R and ODI because it's our gold standard and we've always done it. I am dying. I would like to be the first person to actually get it done to publish just promise outcomes measures. Publish an adult deformity patient paper or pediatric deformity paper with just promise because we need to accept that it's okay. People are averse to acceptance because they don't get it. But it's the future because you need to collect this stuff. You know, we talked about how are we going to get the 10,000 patients into the EMR to get all this data that we need. It needs to be electronic data collection. You need to have patients willing to do it. And no one wants to fill 50 questions to do ODI and SRS-22 and this and that. They want to do a couple promise domains. It works. I think it's great.
Okay, thank you.
Okay. Finish?
Okay, Mike, thank you very much for your time.
Of course, good to see you guys. I hope to see you in real life.
Mike, thank you very much.
I suppose in 2020 we'll just see us by Zoom.
Yeah,